The PFM-M20 GMGHD10 or Majestic-5, it has three names, is a phase 2 study that explores the addition of teclistamab, the BCMA CD3 bispecific antibody in frontline newly diagnosed patients who are transplant-eligible. This is a combination of teclistamab with standard of care, namely Dara, Len, Dex, or Dara, Len, bortezomib, Dex. However, the dexamethasone is only in the first 2 cycles, and bortezomib in one cohort is weekly given. The idea of this study is to explore and leverage on the hopefully and obviously very potent T cell activity of T cells that have not been exposed to any therapy before in newly diagnosed patients, and to hopefully deepen response, especially MRD negativity early on, as we know that all the quadruplet therapies in the last few months and years have dramatically increased and prolonged PFS for patients. There's still room for improvement because MRD negativity, even after transplant, example, is only about 70%. The study design is a multi-cohort study. Basically, to simplify we have 2 main cohorts, one with the teclistamab together with Len and Dara, and the other cohort is teclistamab with Len, Dara, and bortezomib. And all of those patients have been consecutively enrolled in these cohorts. And this is done in a 6-cycle induction therapy, followed by stem cell transplant, hydrotherapy and stem cell transplant, followed by up to 18 cycles of tech and maintenance. So it's a feasibility study. So the main focus is, of course, safety, side effects, infections, CRS, and so on, as with all bispecific antibody therapies. And of course, also looking at efficacy. Of those patients who have completed already the 6 cycles of induction therapy, which is about 50% of the patients, all patients have achieved a complete remission. We have efficacy data after 3 cycles for all patients. And so far, all tested patients, we have 3 patients where we don't have a sample after 3 cycles, but all other 46 patients have achieved a MRD negativity already after 3 cycles, measured by flow at the level of 10 to the -5. In terms of safety, we do not see any surprise in terms of infections or other side effects, knowing all individual drugs quite well, because they're all approved, at least in other lines. What we do see is a grade 3/4 infection so far of about 35%. However, we have not seen any grade 5 infections, probably due to a very strict implementation of prophylaxis, namely antibiotic prophylaxis, at least for the first 2 cycles, were strongly recommended, as well as the supplement of immunoglobulins, mainly IVIGs, as soon as hypogammaglobulinemia, which was basically present in all patients as occurred. In terms of follow-up, of course, for PFS, so it's too short because we're only just sent it and still only have data for now for the induction therapy part. So as I said at the beginning, early achievement of MRD negativity is certainly so far the best prognostic marker for a longer PFS or for long PFS. And as I mentioned earlier, compared to the best available therapies, which is quadruplet induction therapy with a CD38 antibody, Len, bortezomib, and Dex, we have in those few patients so far, of course, but we seem to have a signal that we have a much higher and much earlier MRD negativity rate already after 3 cycles and confirmed for patients with available samples after 6 cycles of induction therapy. So this might lead to a new standard of care regimen, once, of course, in a bigger randomized trial confirmed, where we see patients achieving across the board MRD negativity already in induction therapy, potentially, of course, looking ahead, opening the avenue for limiting the duration of therapy, especially then in maintenance part. No, of course, I want to thank all our patients, their families, and very much so my co-investigator and co-PI, Leo Rashev from the University of Duisburg, and a great collaboration between the GMG study group and the DSML study group, the 2 major German study groups.